Dear colleagues, today I am presenting a case of congenital cataract associated with osteodysplasia. The patient comes to our clinic for a second trimester screening ultrasound, and immediately during the ultrasound examination of the fetal phase, we noticed that the lenses appear distinctly hyperechoic, particularly totally and more evidently in the right eye, and partially in the contralateral left eye, thus presenting a picture consistent with congenital cataract. This is a condition that affects the lens, making it opaque and thus causing visual impairment. In fact, it is the leading cause of childhood blindness. It can present as an isolated condition or possibly be associated with other ocular anomalies, particularly microphthalmia, which, however, has been at least sonographically excluded in this case, or with other systemic anomalies. Bilateral forms are, in most cases, genetic, in 50% of cases. The etiopathogenesis can be endogenous, such as from genetic conditions, syndromes, or possibly metabolic diseases, or the cataract can arise from exogenous causes such as infectious diseases, iatrogenic factors, meaning due to radiation, alcohol, or medications, or as happens in 30% of cases, which is a significant portion of congenital cataracts, it can be idiopathic, meaning the cause is unknown. In the case at hand, the cataract was not the only anomaly detected, since, as we can see from the following ultrasound images, the vital thorax appeared in the sagittal scan to be narrow and disproportionate compared to the abdomen, with a distinctly funnel-shaped morphology. Transverse scan, we can see that the ribs appear to be horizontalized, although they seem to have a regular segmentation judging by the ultrasound appearance. Given the narrow thorax, a relative cardiomegaly also becomes evident, meaning that the heart appears enlarged, not because there is an actual cardiomegaly, but because in proportion to the narrow thorax, it indeed looks larger. Here we can actually clearly see the significant relationship between the air and the cardiac circumference when compared to the thoracic circumference, and indeed the thoracic index definitively confirms a condition of relative cardiomegaly. The anatomical study of the heart was normal, but here the presence of a pericardial effusion about 2.6 millimeters in size becomes evident. The lung fields also appear reduced, as seen in pulmonary hypoplasia, which in the case of a constricted chest is actually the real factor associated with a less favorable prognosis, since it is linked to a high mortality rate at birth. Therefore, the clinical case under examination falls within the broad category of osteodysplasias, an extremely heterogeneous group of skeletal diseases that share common features such as abnormalities in bone development and fetal stature, body disproportion, and variable skeletal malformations. Over time, there have been several classifications. Currently, the most recently used is of the nosology and classification of genetic skeletal disorders, which distinguishes them based on genetic and phenotypic mechanisms into more than 40 different types. In fact, based on their distinct ultrasound characteristics, they can then be clearly distinguished according to the specific body segments involved, and thus precisely classified as micromelia when all segments are significantly reduced in size, as we will observe in the particular case under examination, rhizomelia when the proximal segments are primarily affected, mesomelia when the intermediate segments are specifically involved, and acromelia for the distal ones, that is to say, the hands and feet. Whenever there is a suspicion of osteodysplasia, it therefore becomes essential to conduct a more in-depth ultrasound study by evaluating the entire long bone, assessing not only its length but also its shape, the degree of ossification, and the possible presence of fractures. The thorax and ribs, the hands and feet, thus not only their morphology but also the posture and fetal movements during the ultrasound examination, the fetal spine, the skull and face, and the internal organs. In the case under examination, as mentioned, there was micromelia, meaning that all the long bones of the proximal, middle, and distal segments, both of the upper and lower limbs, were extremely below what would be expected for the gestational age, even though they showed normal morphology and regular structure. Therefore, fractures were ruled out. In fact, we can clearly observe that the femur, the tibia, the fibula, and the feet are all significantly smaller than what would be expected for the gestational age, and precisely the same goes for the upper limbs. So the humerus, the ulna, and the radius were also notably smaller than anticipated for the age, as was the clavicle as well. Obviously, the measurements were carefully and precisely taken for both the lower limbs and both the upper limbs in order to rule out any potential asymmetries. And indeed, in fact, we can very confidently say that the overall biometrics were quite remarkably comparable for the different segments, specifically on both the right and left sides of the body. The fetus's hands were consistently in a closed fist position, so it was not possible to further examine the fingers in order to rule out or possibly confirm an association with polydactyly. Therefore, this assessment will need to be performed at the time of birth. The fetal spine, on the other hand, appeared normal both in the cervical and thoracic portions as well as in the most distal section at the sacral level. Here you can see various nomograms for different bone segments of the upper and lower limbs, along with the overall fetal biometry. There are several genetic conditions in which there is an association between congenital cataract and osteodysplasia. Some of these are shown here on the slide, or you can refer to online portals like Orphanet, but in general, it is impossible to make a definitive diagnosis based solely on ultrasound evaluation. Therefore, the patient was referred for genetic counseling and ophthalmologic consultation in order to assess the prognosis related to congenital cataract and the possible treatment options at birth. Infectious disease markers were recommended due to the association with cataract and the presence of the pericardial effusion. Ultrasound follow-ups every 3 to 4 weeks were recommended, mainly aimed at assessing relative cardiomegaly and the progression of pulmonary hypoplasia, as well as monitoring fetal bone growth. At the time of birth, a neonatal follow-up will obviously be necessary, in particular the performance of a thorough and complete radiological study and a psychomotor assessment of the newborn to investigate any association with possible motor deficits or joint stiffness, and thus to rule out any neuromotor disorders. Thank you for your attention.